So hello everybody, and thank you very much for joining me this afternoon. Tomorrow we will have a live talk about the frontal sinus, and for today I've elected to rebroadcast a very valuable lecture that I had listened to together with Dr. Anil Lalwani from Columbia University about cholesteatoma in the year 2020. So here we go. Enjoy.
Hey, Muaz, can you confirm that you can see my slides on the screen?
Absolutely. Yeah, everything is good.
Terrific. Well, first, Muaz, I think congratulations to you on establishing your Ear and Sinus Institute.
Thank you.
That's an incredible achievement. It represents, I think, excellence in all areas. And, you know, I think you represent excellence in all areas of otology, sinus surgery, and so on. So it's really, anyway, congratulations from me to you. I've had the opportunity to visit Muaz in Dubai in the past, and I don't know if you all know Muaz personally, but he's one of the hardest working people I know, one of the smartest. And it's not a surprise to me at all that he's accomplished all that he has already. Anyway, Muaz, thank you so much for making me part of the program.
I think you're just too kind, Anil.
So my goals this morning really were to broadly talk about cholesteatoma. Will talk about some aspects of tympanoplasty that'll be really helpful to you, I think. But the first thing that I would like to do is kind of orient you to where I am in New York. So I'm at Columbia University. If you look at this figure of Manhattan, this is where the World Trade Center used to be in the past. The United Nations up here on the northern parts of Manhattan. This is New Jersey. The Times Square is in this area. The Golden Gate Park, or the Central Park. Golden Gate Park, of course, is in San Francisco. The Central Park is up here, and Columbia is in a very much the northern part of Manhattan. So here's the picture of the Columbia University, the main campus, and approximately a mile and a half away, right on the Hudson River, is the medical campus of Columbia University. It's really well known for its heart center. This is where Bill Clinton came to have his heart surgery, where Hillary Clinton came when she fell and had some neurological issues several years ago when she was running for president, and so on. A lot of really impressive things have happened at Columbia. It's a wonderful institution. It has strengths both in clinical areas, basic science, engineering, and one of the things that I've really benefited from during my time at Columbia over the last 8 years is an opportunity to collaborate with some very, very smart people. I also thought I would just briefly let you know that the 4th edition of the Current Diagnosis Treatment was just published earlier this year. The book is now in color. Much of what I will talk about during this hour, you can be found in this book. It's available, of course, online as well as in paper. It's I think been translated previously in Spanish, Turkish, and Portuguese. So I look forward to its continued success. So, and during the next 50 minutes or so, I'm going to talk about congenital and acquired cholesteatomas, the etiology of cholesteatomas, clinical presentation, radiology, what's its role, surgical intervention, canal wall up, canal wall down, what's different about congenital cholesteatoma and how to treat those surgically, and finally, what's the prognosis for cholesteatoma? Do they have to be followed for the rest of their lives or not? Well, let's start with the term cholesteatoma. It really comes from the word, the Greek word for chole, or for bile, and steer for tallow, like the little, what cholesterol crystals look like histologically. But as most of you know, cholesteatoma, of course, has nothing to do really with cholesterol per se. It is really a skin cyst. And I suspect the more appropriate term of keratoma will never really replace cholesteatoma, much like vestibular schwannoma has never really replaced acoustic neuroma. It's a term that we're all familiar with, that we are all using, but it's important to know the background. Now, there are three different kinds of cholesteatomas. Congenital cholesteatoma, there's several criteria for it. We'll talk about primary acquired cholesteatoma. That is the cholesteatoma arising in a retraction pocket. That's what most of us think of when we think of cholesteatomas. These are the ones that occur in the epitympanum or the mesotympanum. And secondary acquired cholesteatomas are those that arise in the setting of a tympanic membrane perforation. That is, there's an ingrowth of skin. I have to admit, for the longest time, I didn't really think they existed, these secondary acquired cholesteatoma. As I've gotten older, I've seen a few of those. So it's not very common to have cholesteatoma implanted in the middle ear, but it can occur. So let's take a look at a congenital cholesteatoma. This is a right eardrum right here. We're looking at the umbo, the vascular strip, the short process of the malleus, and of course the epitympanum. So this is anterior towards the nose. This is posterior. The incus would be right here. Now, there are a lot of classifications as to what a congenital cholesteatoma is. And in my mind, there are really two things that have to be really kind of present. One is that it has to occur behind an intact eardrum. So if it's congenital, if it was there from birth, you shouldn't have that ongoing drainage from a retraction pocket. And number two, there really shouldn't be a very strong history of ear infections. Now, ear infections can occur. The complication, of course, with ear infections is that ear infections alone can eventually lead to acquiring a cholesteatoma, so it confuses the picture. But the third thing in my mind is also the location of the congenital cholesteatoma, which is in the anterior superior quadrant of the eardrum, of the mesotympanum. And this has implications not only for diagnosis in terms of location, but it also has implications for how you would approach this surgically. That is, a cholesteatoma that's located here on the posterior mesotympanum, like the mesotympanic retraction pocket cholesteatomas, versus epitympanic cholesteatomas would be addressed differently surgically. So we're going to talk about that as well as we go along. Where do these cholesteatomas and the congenital cholesteatomas arise from? They're thought to arise from this epidermoid formation that's normally present in the anterior mesotympanum in the middle ear, that normally undergoes apoptosis and disappears. So by the time a baby is born, a newborn does not have this rest of epithelial cells. In cases of congenital cholesteatoma, this epidermoid resting cells can persist. And that's why there is a location, the predilection of location for these congenital cholesteatomas in the anterior superior quadrants. For reasons that are not clear, it's more common in males as compared to females with a ratio of 3:1. In my mind, it doesn't have any surgical implications or diagnostic implications per se, but it's important to know that. How about acquired cholesteatoma? Well, there are three different ways that acquired cholesteatomas are thought to be acquired. One, and probably the most common and the most one that we're familiar with, is that the immigration and invasion theory of cholesteatoma. That is that there's a retraction pocket, and from the retraction pocket, whether it's up here in the epitympanum or whether it's here in the posterior mesotympanum, is from there the skin migrates. Now, what's fascinating is that there's some really interesting work being done by Aaron Tward, T-W-A-R-D, at UCSF, that looks at how skin migrates from the eardrum peripherally towards the outer ear canal. The migration that we all are familiar with, how wax eventually comes out of the ear canal. And I suspect that in the work that he's doing, there is a scientific explanation for why some retraction pockets turn into cholesteatomas, why others don't. So I think there's some exciting work coming in this area. There's also the implantation and invasion theory of cholesteatoma or acquired cholesteatoma. This is where the epithelium is implanted into the middle ear, whether it's from surgery or whether it's from trauma, or from a perforation, margins of perforation. And finally, metaplasia. That is the lining, the cuboidal lining that normally lines the middle ear space turns into keratinizing squamous epithelia. In my mind, I suspect the number one is immigration and invasion. I think much less commonly is implantation and invasion. And finally, I think metaplasia sometimes is really hard to diagnose, in large part because if it occurs in the setting of chronic infection, something akin to how when there's chronic otitis externa in the ear canal, there's a arising of squamous cell carcinoma or something. So the metaplasia doesn't occur by itself, but it probably occurs in the setting of some chronic inflammation. I can't really say if I've seen a case of metaplasia in my 30-year experience, but it is one of the ways an acquired cholesteatomas can arise. Now, the other really fascinating things, and this is the artwork from my mentor, Rob Jackler, who was at UCSF at that time and is currently the chair at Stanford. And much of the artwork you'll see, except some new artwork from a surgical atlas that I'm doing, is from Rob. And you know, Rob's just a phenomenal teacher, and many of the artwork that you'll see shows how he's a sort of a very clear thinker, and I want to make sure I transfer some of that clarity to you. So if you think about where the cholesteatomas arise, so the acquired epitympanic or mesotympanic retraction pocket cholesteatomas, these acquired cholesteatomas, the three most common locations are the posterior epitympanum next to the neck of the malleus, the mesotympanum, the posterior superior mesotympanum, and finally the anterior epitympanum. Now, depending on where the cholesteatoma is arising will determine what it destroys first, how it expands, and where it expands to. And what determines that is all these ligaments. Now, I have to tell you that I don't think I've ever memorized the name of these ligaments, even though there's been wonderful anatomical papers written about them. But what I do know is that these ligaments ultimately determine what happens as the cholesteatoma grows. So let's take a look at this case of epitympanic retraction pocket cholesteatoma. That is above the short process of the malleus. Well, you already know that this cholesteatoma grows. It's going to be on the lateral or outer surface of the ossicles. So the first thing that the epitympanic cholesteatoma will destroy is the body of the incus and the head of the malleus. And then as it erodes it, it will expand into the mastoid cavity. It can, as it grows bigger, it'll expand into the anterior epitympanum as well. But really, the large part of destruction from epitympanum is the erosion of the body of the incus, the long process of the incus down here in the posterior mesotympanum, as well as the crura of the stapes are intact. Now, it's not that epitympanic cholesteatoma eventually can't become so big that they destroy everything, but really early on, they tend to destroy the body of the incus first, and they maintain the stapes superstructure. And that's kind of nice because, as you know, reconstruction afterwards depends, the success of it anyway, depends on the presence or absence of the stapes. Because if you have the stapes, first of all, stabilizes your prosthesis, but it also offers the mechanical advantage of the stapes structure in amplifying sound from the eardrum to the inner ear. So epitympanic cholesteatomas tend to be favorable in that regard, in that they leave the stapes alone, at least in the earlier stages. The other good thing about epitympanic cholesteatomas is they tend not to drape over the facial nerve, because first they have to grow through the incus before they go on to the floor of the epitympanum. And that's why if you catch an epitympanic retraction pocket cholesteatoma early, and all it's done is erode the scutum, you can simply do an adichotomy exteriorize this area, and that's sufficient. You don't have to touch the ossicles. But I suspect in most of your experiences, as well as mine, there are not very many attic cholesteatomas simply confined to the attic where that operation is sufficient. How about mesotympanic cholesteatoma? Well, I have to tell you, these are my least favorite of cholesteatomas, and I'll tell you why. Number one, where do they grow? Well, they start in the posterior superior quadrant of the eardrum. And what's right underneath the posterior superior quadrant? Long process of the incus, the stapes superstructure, the oval window, and the facial nerve. And this cholesteatoma grows underneath the incus as opposed to on the outer surface of the incus. So what does it do? Erodes the long process of the incus. It very early on erodes the superstructure of the stapes. It's draped over the promontory. It's draped over the facial nerve. I find the mesotympanic cholesteatomas to be just much more painful to take care of. So I think that's really helpful. So when you see a patient and you know where the cholesteatoma is arising from, whether it's a retraction pocket in the mesotympanum or a retraction pocket of the epitympanum, you already have a mental picture of what that cholesteatoma is going to look like, what you're going to do surgically, where are your bottlenecks during the procedure, and what are the biggest risks to the patient. So let's move on to the question of when is a retraction pocket a cholesteatoma? So if you're looking at this left eardrum, here it's really kind of obvious there's a cholesteatoma in the posterior quadrant, but it really arose here and it came like a little grape hanging down from the epitympanum and the posterior mesotympanum. But when, let's say if you only had this pocket in isolation, when does that become a cholesteatoma as opposed to simply a retraction pocket? Or you have to do surgery? Well, if it starts to have retained keratin, that is skin in here that you can't clean in the office, let's say it's above where the bony margins are, that's a surgical cholesteatoma as opposed to a medical cholesteatoma. If the patient has recurrent granulation tissue and otorrhea, that's a surgical cholesteatoma as opposed to an office-based medical cholesteatoma. And lastly, there's a lot of bone destruction going on, especially as you begin to erode into the ossicles. As you can see, if you look at this epitympanic retraction pocket cholesteatoma, part of the head of the malleus is missing, part of the tegmen is missing. This is a cholesteatoma that requires surgery, even though it isn't very big, at least when you look at this picture. Also appreciate the facial nerve. And remember I was saying how epitympanic retraction pocket cholesteatomas don't early on drape over the facial nerve. So you can see the facial nerve is entirely clear. The floor of the epitympanum underneath the malleus is clear. So moving on to clinical evaluation of congenital and acquired cholesteatoma. We're again looking at that right-sided congenital cholesteatoma. What's the history? Sometimes hearing loss, they might present with hearing issues. They hardly ever complain of pain. There's hardly any history of otorrhea because this is a growth behind an intact eardrum. Usually a pediatrician or an ENT doctor picks it up. On exam, there's usually some kind of whitish mass behind the eardrum. There's no facial nerve symptoms. And if with the aid of a microscope, you can often, but not always, differentiate tympanosclerosis from a congenital cholesteatoma. They often have a conductive hearing loss due to impingement on the ossicular chain, and a CT scan shows a whitish mass in the anterior epitympanum. And people will often ask, do you get a CT scan for a congenital cholesteatoma? Let me tell you up front, I personally get a CT scan on every patient that I'm going to operate on. And that's because it immediately tells me the extent of the disease, my surgical approach. I will have done the surgery in my head before I ever get to the operating room. I'll know the status of the tegmen, the inner ear, have some idea about the ossicles, and also, more importantly, know if the facial nerve has a normal course. So for me, a CT scan really is a roadmap to doing the surgery. I look at it several times when I see the patient. I see it the night before, I see it the day of surgery. And for me, it is it is something that I will not hardly ever operate with on a patient. But others do not get CT scans for congenital cholesteatomas. Sometimes they don't even get CT scans for acquired cholesteatomas. And in congenital cholesteatomas, there's a tendency not to get it when you can see the margins of the white mass. And this is a axial CT. It's very poor quality, and I apologize for that. This is a coronal CT. What you see is that here's the malleus right here. This is the eustachian tube. There's a soft tissue in the anterior superior mesotympanum, exactly the location of that white lesion I just showed you. And this also shows you underneath the eardrum on a coronal imaging. So this is a very nice congenital cholesteatoma. I just did a congenital cholesteatoma yesterday in a kid who had bilateral congenital cholesteatoma and also had a COVID infection less than 3 weeks ago, all right? And I have to tell you, on both sides, the cholesteatoma occupied the entire middle ear, epitympanum, and the mastoid cavity. Yesterday, the facial nerve was dehiscent in the anterior tympanic portion, the most common area to injure it when you have an anteriorly based cholesteatoma. So congenital cholesteatomas can be small like this, or they can be quite big. And in my experience, there's really two categories. There are the benign acting congenital cholesteatomas like this, and there are the more aggressive types that really are very destructive and destroy the bone. And this poor kid had no incus, had no stapes, and will have, not a great reconstructive outcome after his second look operation. How about acquired cholesteatoma? I'm just going to check my time to make sure I'm not taking too long. Good. So an acquired cholesteatoma, there's almost always otorrhea that doesn't respond to ear drops. That is, they may respond temporarily, but it comes back. They often have hearing loss. They can have facial nerve symptoms. And when you look at the eardrum, there's either a retraction pocket or an attic defect in the epitympanum or in the posterior mesotympanum. There's usually keratin debris. And on those really severe cases, a fistula test may be positive. They usually do have a conductive hearing loss on a hearing test, but sensorineural hearing loss is also possible. And as I mentioned earlier, I get a CT scan because it defines the extent of disease, presence or absence of ossicular erosion, facial nerve anatomy, as well as presence or absence of inner ear fistula and the tegmen. So let's take a look at examples of this. So here's a CT scan of the temporal bone of the right ear, axial and coronal. So if you look at this picture right here, you see soft tissues around the head of the malleus, the body of the incus. What else can you tell? Well, you can tell that the facial nerve right here, the tympanic portion of the facial nerve, the labyrinthine portion of the facial nerve, first genu, it's bony covered. Now, I don't necessarily trust the CT scan, but at least it's helpful to me know that it's probably bony covered. I still should be careful, but that's helpful. You can see that there's soft tissue within the mastoid cavity that's well pneumatized. Well, I might want to avoid a modified radical mastoidectomy in this individual because he has a relatively well pneumatized mastoid cavity that may be very large. The inner ear looks normal. There appears to be no fistula. So there's a lot of information here to be seen on a CT scan. Here's a coronal imaging. And what you see is soft tissue underneath the eardrum. Here's the malleus. Here's the head of the malleus. Soft tissue. Here's the facial nerve, the labyrinthine portion of the facial nerve, and the tympanic portion of the facial nerve. The snake eye that people often will talk about. Here's the cochlea. And sadly, just posterior to this, the stapes is gone, the facial nerve is dehiscent, and the soft tissue is right on the lateral surface of the facial nerve. Now, the moment I see this image on the bottom, I know that this is a mesotympanic retraction pocket cholesteatoma, right? Because what is it doing? It's growing towards the oval window, onto the facial nerve, and underneath the ossicles, as opposed to scutal erosion and growth on the lateral surface of the ossicles. So the CT scan can be quite helpful in looking at the extent of disease. Also, you can tell that the tegmen is intact. Well, here's two examples of where there's a fistula of the lateral semicircular canal and a very contracted mastoid cavity. Here's a much larger fistula, and you can look, when you look at the soft tissue, you get the idea that this is expanding around, right? It gives you a sense that there's something erosive, in addition to the fact that, in fact, the lateral canal has a fistula from the cholesteatomas. This is very important as you prepare to see, are you going to do a canal wall up? Are you going to do a canal wall down? And I'll tell you, just because a fistula is present in my mind, you don't necessarily have to do a canal wall down. If there is a granulation tissue on top of the lateral surface of the fistula, you can leave the granulation tissue down while you lift the matrix up and leave the canal wall up. So there are a lot of different options, even if they do have a fistula, but knowing that they have a fistula is very important, so you don't lift up the matrix and expose the inner ear, especially a hearing inner ear, to potentially having profound sensorineural hearing loss. This is a coronal CT scan that shows a big tegmen dehiscence. You can also see a fistula of the lateral canal. There's also superior canal dehiscence, and there's soft tissue. So a CT scan, especially coronal CT scan, can be quite helpful in knowing the presence or absence of dehiscence of the tegmen. And more importantly, the more important thing to look for, even more than this dehiscence, is what does the lateral dura do? What does the temporal lobe do here towards the cortex? Because the number one place to injure the dura isn't here. You're going to be ready for this. It's right here at the cortex, because when you start drilling away, if this thing comes down here and then goes back up, the first thing you're going to get with that cutting burr as you're trying to do your cortical mastoidectomy is going to be the dura. You're going to have encephalocele, CSF leak, if you're not careful. And the CT scan can tell you whether the temporal lobe comes low and then goes back up or not. You can be prepared so that you don't injure the low-lying tegmen, especially towards the outside, so that your first few swipes of the cutting burr doing a mastoidectomy doesn't lead to significant injury to the brain. So to summarize, for congenital cholesteatomas, people feel like you don't necessarily need a CT scan, but I do get it. For acquired cholesteatomas, I think it would be more risky if you proceed without a CAT scan for all the reasons I've just discussed in the last few minutes. How about the surgical options? Well, there's basically sort of three approaches: transcanal, canal wall up, canal wall down. And I know Dr. Tarabishi has a presentation on endoscopic ear stuff. And now you actually have a lot of things in your armamentarium. If you're going to do a transcanal, you have the endoscope or you have the microscope. So I won't cover the endoscope per se. Dr. Tarabishi is a much more of an expert in this area. But I'm just going to talk about the different surgeries that can be done. How you do it, I'm going to leave to your experience. So you can do a transcanal if there is simply a hole in the eardrum, do a tympanoplasty, maybe just an adichotomy. You don't have to do a mastoidectomy for those small epitympanic retraction pocket cholesteatomas. Then there's this big separation between canal wall up versus canal wall down, or a modified radical mastoidectomy or a radical mastoidectomy where even the eardrum is taken away. I will tell you, if you're going to do a canal wall up, you should pretty much do a facial recess in every one of your cases. It is going to allow you to see the middle ear better. It'll allow you to get rid of disease that's often in the facial recess that you cannot get rid of from the ear canal necessarily. You may be able to do so with the endoscope. But in my experience, facial recess, if you're doing a microscope-based approach, is critical, and also allows you to see how your prosthesis sits after you put your eardrum back down when you do reconstruction. So let's talk about how do we do surgery for congenital versus acquired cholesteatoma. So again, this is a picture from Dr. Jackler. He shows that there's a mass like a congenital cholesteatoma. This is the only time I disagree with Rob. He shows incisions like this, where he has a 6 o'clock and 12 o'clock. That's not what you should do. What you should do for a congenital cholesteatoma is make an incision at the 3 o'clock, right anterior ear canal. Bring it all the way around so that you can lift this entire flap inferiorly. You may, and that's because you may have to take the eardrum off of the malleus to be able to approach this mass that's anterior to the malleus. So your incision for a congenital cholesteatoma for raising a flap is not your typical tympanoidal flap. You should do an almost 3/4 of a flap based superiorly like this, come all the way around and lift it and peel that eardrum off of the malleus. Now you can leave it attached to the umbo or you can take it off. It really doesn't matter. It'll heal back down. The other thing is if you're concerned that there's going to be a lot of manipulation of the ossicles during surgery, the first thing you should do is separate the IS joint. If you believe that you will be banging on the ossicles, separate the joint, it will re-heal, but that way you'll minimize trauma to the inner ear during the dissection. So here, Rob's work has shown that you can just take it off of the umbo entirely. This gives you nice access. I don't always do it, but I have no problem doing that. I'll leave it attached, and I can usually work with a little whirly bird, bringing it from the front to the back if it's small, or debulk it in the center, collapse it, and then dissect it towards itself. The biggest problem with congenital cholesteatomas really is they have a lot of mucosal adhesions all around, which makes it sometimes difficult to pop them out. I suspect if Muaz was given this talk, he would definitely tell you use the endoscope because your visualization will be beautiful. I find that my exposure with microscope is also quite reasonable. After you resected it, you can put the eardrum back down. Usually for small congenital cholesteatomas, I usually don't do a second stage, and usually ossicular reconstruction is not required. Now, how about acquired cholesteatomas? So you know there's canal wall up and canal wall down. So what are the indications for canal wall up mastoidectomy? Well, one indication is that if you have extensive mastoid pneumatization, if you did a canal wall down, you would end up with a very large cavity that's difficult to clean and maintain. And the other is indications if you have a reliable patient, because they'll need follow-up, right? They'll need a follow-up surgery to make sure the cholesteatoma hasn't come back and ongoing monitoring. Because as you know, cholesteatoma really is a lifelong disease because the underlying condition that predisposes you to cholesteatoma is your stage 2 problems. But the other considerations include, the advantage includes self-cleaning ear. It's a very normal ear where the wax normally migrates out. You don't have to worry about water. The acoustics are normal, at least in the sense that the ear canal anatomy is maintained. And the disadvantage that people talk about is there may be higher recurrence rates. I am not convinced that's in fact very true, especially if you do 2-stage operations. If you do only 1 stage, I think that's probably true. But if you do 2-stage operations, and I do all my canal wall ups as 2-stage, and one of the things that I do differently is I do the second stage at 4 months, not 6 months, not 1 year. And why is that? That's because at 4 months, if the cholesteatoma has recurred or there was something that was left, it's going to be big enough for you to see it, right? But if you wait 6 months to a year, the cholesteatoma will have regrown to a much larger size. So if I do my surgery early, not only can I safely get whatever recurrence is there, but I can avoid future surgeries. Whereas if you wait a year, as many people do, I think it's a disservice to the patient. So if you are waiting 6 months to a year, go at 4 months. The ear's already healed. You'll know if there's a recurrence or not. And if there's a recurrence, they tend to be small, almost a pearl-like thing. You can dissect it out better and easier and without any risk for recurrence in the future. How about canal wall down mastoidectomy? Well, the indications are, well, if you have a contracted mastoid and that results in poor visualization, your cavity won't be very big to begin with, right? True. Number two, if you have a fistula, you should really consider canal wall. You should do canal wall down, because that way you don't have to lift the matrix up. But remember, somebody with a fistula and you leave the matrix now with the canal wall down exposed to the outside world, those guys are really sensitive to temperature changes and they often get dizzy. So if the opportunity is there and I can get the matrix off and there's a layer of granulation tissue, I favor a canal wall up, even if they have a fistula. I've got plenty of those kind of cases and they do great, and they don't have to get their ears cleaned every 6 months and experience dizziness at your hand. They don't have to worry about not being able to swim and so on. And the other indication people say is, well, you know, if the patient is unreliable, who won't come back, and you're worried about recurrence, if you do canal wall down, there's a lower recurrence rate. Now, to me, that makes no sense, because if you do a canal wall down mastoidectomy, they got to come back to you every 6 months for cleaning. If you have an unreliable patient, the last thing you want to do is a canal wall down mastoidectomy. So I think unreliable patient is a contraindication to doing a canal wall up. At least there's a likelihood he'll show up for the 2 surgeries, and even if he never shows up down the road and you've done a good job, he'll never need you. Or if you do a canal wall down, he's going to need you every 6 months. He or she's going to need you every 6 months. So if he's not reliable, I'm not sure if you should be doing canal wall down. And those speak directly to the disadvantages that I was just talking about. So I have to admit now, when I was younger, and I mean like 25 years ago, I did 95, 99% canal wall up and very few canal wall down. And as I've gotten older, I have to admit, I do more canal wall downs than I do canal wall ups. I don't, than I used to. No, I still do mostly canal wall up. But I'm less against doing a canal wall down than I was when I was younger. And I still try to avoid canal wall downs in children because they're not going to let me clean that mastoid cavity. I don't want to put them to sleep every time on it just to clean their mastoid cavity, and therefore I avoid it at all possible if I at all can. I do not take the canal wall down in kids. Now there are some kids you can't do anything different, and I understand that. But I've become more liberal in doing the canal wall down in my adult patients, especially if they've had a recurrence. Because, if their underlying disease leads them to recur their retraction pocket despite all the different maneuvers you might have done, then I think they need a canal wall down. All right, how about the surgery itself? What are some of the steps? So here's some key points that I want you to take away. When I do a canal wall down, I'll make the posterior incision and I'll address the mastoid part first. So clean out the mastoid cavity, come up to the additus ad antrum right here at the beginning of the epitympanum, and that's where the incus is. And usually I don't always know what the status of the IS joint is, so I don't want to do any trauma from my surgical manipulation of the matrix. I don't want to drill in this area and drill on the ossicles and cause a hearing loss because the ossicles may be intact. So I'll do the mastoidectomy, always stay outside the capsule, especially along the posterior and superior margins here on the slide, and dissect forward, make a little incision, debulk the center, much like you would do an acoustic neuroma if you were doing acoustic. So make an incision in the capsule laterally, because you're never going to leave the lateral capsule behind. You might leave the posterior capsule, you might leave the superior capsule, you might leave the medial capsule because you didn't dissect correctly, but the lateral is never a problem because you've taken away the bone. So you make an incision right in the center, debulk it in the center, dissect the matrix forward, and cut out all the cholesteatoma, leading to the incus. You should also take a few minutes to make sure the ear canal is nice and thin so you're ready for the facial recess that you'll end up doing. And there's a really easy facial recess to do because if you thinned it out and after you remove the incus, you can literally start from the epitympanum and go inferiorly towards the tympanic portion of the facial nerve. It takes 5 minutes to do. Your facial recess can be done in 5 minutes if you have already thinned the ear canal down to the level of the lateral canal and remove the incus, as almost all cholesteatomas will require. So we've done the mastoid part. We're down to where the incus is beginning. You can maybe palpate the body of the incus with a Rosen needle, or you can see it visually. You've opened up the epitympanum anteriorly, lateral to the ossicles as much as you can, and then you go to the middle ear. And I like the laser. I personally prefer KTP laser because there's a little green dot that's very precise. I find the CO2 laser not to be precise in my hands. I like Rosen needle, and I especially like joint knife to allow me to dissect on the oval window. Now, I want to spend just a few minutes because I suspect that whether you do cholesteatomas or not, you probably do a tympanoplasty. And if I was to survey in this talk right now of all the attendees, and I said, all right, where do you make your incisions for your flap? I suspect that 90% of you would tell me, well, you make an incision at 6 o'clock and at 12 o'clock. I'm about to tell you that get away from this mindset of doing an incision at 6 o'clock and 12 o'clock and rethink in terms of what those incisions are trying to accomplish, especially where the perforation is. All right, so let's go through some examples. And this artwork, by the way, beautiful artwork by Julia Lerner is from my new book, The Surgical Atlas of ENT, where I'm going to have 50 common procedures. It's almost like a cookbook with very few words, mostly pictures, instruments. It kind of has some nice little things you'll be able to review before going to the OR to make sure you're ready mentally to do the case. So here's the chapter on tympanoplasty where here's your classic perforation in the posterior quadrant, right? This is the right ear, malleus, incus, epitympanum. So you make a classic incision at 6 o'clock. You always want to make the incision superiorly, just slightly anterior to the short process. As you flip this tympanoidal flap forward, the axis of rotation can be the malleus. This is a 6 o'clock, 12 o'clock is perfectly fine for posteriorly based perforations. However, as those perforations become more anterior, one of the key rules that I want you to walk away with is that the anterior extent of your incision should be anterior to the margin of the perforation. So if you just did your incision right here, your 6 o'clock and 12 o'clock, you won't always be able to see the anterior margin of the perforation. So you'll be struggling a little bit about in terms of placing your fascia graft or alloderm allograft, whatever you might use. So make your incision at least anterior to the anterior margin of perforation. And by the way, I've pretty much gone away from making the superior incision. I'll make it just a tiny bit, lift this flap, because mostly you need to see inferiorly. You don't need to make this thing. And by having the superior part of your skin intact, the eardrum lays back nicely too, but making sure that your incision is anterior enough allows you a beautiful exposure to the anterior mesotympanum and the anterior margin of your drum. It'll make it very easy to put your grafting material. Now, how about this perforation in the anterior superior quadrant? It could be a perforation after a placement of a tube. This is a very hard perforation, right? I think the fascia tends to fall away. So here, I recommend that you do something called a hammock tympanoplasty. First of all, make your incision all the way in the front. If the perforation is up to here, come all the way up here, come all the way around to here. And then elevate the flap. And so now you'll have 3/4 of the ear canal skin elevated. And the next thing you'll do is when you place your fascia, you'll place it from the anterior ear canal to the posterior ear canal, much like a hammock. The anterior fascia can't fall away because you placed it onto the bony ear canal. But you have to adjust your incisions. So if there's one of several things that I want you to walk away with today, get away from this idea of a 6 o'clock, 12 o'clock incision. Make the inferior limb as anterior as you possibly can, certainly anterior to the perforation. Superior incision you hardly ever need, at least not for most of your tympanoplasties, unless the tympanoplasty is really up here in this area, which is unusual. And how about actually making the flap? So, I think many people will make the cuts in the ear canal, come to the mastoid, and then lift up the ear canal skin to find where the incision is. I don't do that. So I just drilled away the spine of Henle. I think that's a very smart thing to do. And I use a very pointy Bowie cautery to make my incision into the ear canal. It's not bloody. It's easier. You always kind of make it medial to the bony cartilaginous junction. If you start doing this, you'll never go back to using a knife or going to making transcanal incisions beforehand. This is much easier. You raise your flap with your suction, watch your round knife fall into the middle ear, and then go and do your next step. So once you enter the middle ear, you lift up the eardrum, and much like you did in the mastoid cavity, you debulk the cholesteatoma. And the most important thing you need to do here is to find out if the incus and stapes is intact. Because if it's not intact, then you can go back, take the incus out, take the head of the malleus out, cut the tensor tympani tendon, clean out the entire epitympanum, connect it to the middle ear, clean out the middle ear. If the incus and stapes is intact, separate the IS joint, remove the incus. Or if it's not coming easily, laser, if you have laser this part of the incus, amputate it, and remove the incus, because the incus has to go. It really doesn't matter whether you have an epitympanic or mesotympanic retraction pocket cholesteatoma. The incus is in your way. And the head of the malleus is worthless. You need to take the head of the malleus out. And once you do that, I talked about the argon laser. I won't talk about the otoscopes, of course. The last part really that you do is the matrix over the stapes itself. And so you work both from superiorly, you work from inferiorly, you come from anterior, come from posterior, and very delicately remove the matrix over the stapes. If it's going through the crura, which it can sometimes, you can't leave it behind. And if it doesn't dissect freely from between the crura, you'll have to laser away the stapes and then dissect the matrix out, because you're the last hope against this cholesteatoma not coming back. If the malleus is medialized, cut the distal part off. It'll make it easier to graft, put the cartilage, and I use cartilage in every one of my cases, whether it's a regular tympanoplasty or a tympanoplasty with cholesteatomas. In the canal wall down, so the only point I want to make about canal wall down is that I do a canal wall operation first, do the recess, and at that point I decide that I can't get everything out safely and I need to take the canal wall down. Then I will just simply take the canal wall down. And then you can do it safely because you already have done a facial recess. You know exactly where the facial nerve is. And of course, make sure your facial ridge isn't very high. Take that down. If you're not comfortable with taking it down, maybe you shouldn't be doing this operation, because if you leave this high, if you leave the facial recess high, it'll make it very hard to clean out the mastoid cavity. And of course, the most important thing about a canal wall down is make a huge meatusoplasty. Make sure you can put your thumb in it, or at least one of your fattest finger you can, into the meatus before you end that procedure. Because otherwise, you're going to have a really hard time cleaning the mastoid cavity. Reconstruction, whether it's a PORP, I won't show you this. This is just, I love the Sheehy's PORPs and TORPs. I make a little slit in it at the bottom, so it sits nicely over the stapes, very easy to trim. Here's a torp. I don't really care for the torps. Torps results are just, they're not as consistent as a porp, and that's why that stapes superstructure is so important. And if you have a stapes present and you can do a porp, 3/4 of the time, your air bone gap is going to be less than 20 decibels. But if you don't have the stapes, more than likely they're going to have about 30 decibel, 25, 30 decibel air bone gap. I like to use the cartilage to reconstruct the scutum. I will sometimes place a silastic in the epitympanum to make a little blockade in the attic so they can have a retraction pocket. You can leave a silastic, by the way, forever. There's nothing wrong with leaving silastic to block off the mastoid cavity. I was going to show you that here, but I know I'm running out of time because I've talked way too much. How about to stage or not to stage? For my T mastoids, I stage all of them. I do. I get MRI scans in some cases where there's a question mark, but really I have not been able to trust the MRI scans alone to know whether a cholesteatoma has come back or not. And I do it in 4 months. Facial nerve monitoring, yes. If it was my mother or father you were operating on, I would insist upon it. I think you should know your anatomy and where everything is, but the facial nerve monitoring is another tool, just like your microscope is a tool, just like your endoscope is a tool. It's a tool to do your surgery safely. How about the difference between between adult and pediatric cholesteatomas? Preoperatively, children tend to have lower incidence of complications compared to adults. And postoperatively, the most significant difference is there tend to be much greater residual and recurrent disease in kids. And some of the risk factors, I think I am going to start summarizing here because we're close to being done here. And I'm down to my last 3 or 4 slides anyway. There's a recurrence risk in kids of 24% versus 6% based on very old literature. I think, I suspect they both do pretty well in 2020. Where do the recurrences occur when they do? They occur in the oval window, the facial recess or the sinus tympani. They do not occur in the mastoid. So if you're having issues with occurrence in the mastoid, something is not right because the mastoid is the easiest part to take care of. And I suspect the oval window, facial recess, sinus tympani are good places to visualize with the endoscope. Young age and ossicular erosion was strongly related to recurrence and residual disease. So if you have ossicular erosion, it's a more aggressive cholesteatoma. I don't personally find that very helpful that it's being as a predictor, but if you've got ossicles eroded, it probably is a more aggressive cholesteatoma that may recur. And this is just showing a nice picture from Vagelas' atlas of a recurrence in a sinus tympani as opposed to a facial recess, and this is the facial nerve. Yep, we talked about endoscope. Finally, cholesteatoma is really a lifelong disease. You got to follow these kids, these adults. I don't know if MRI will be the answer that answers all the questions, but certainly on certain cases you can avoid having to reoperate where you think the likelihood is quite low. And I think that's it, Moaz.
Thank you very much. It's a great talk. Thank you, Neil. Really enjoyed it. One big take-home message about the location of the 2 limbs of the tympanomeatus flap is really, I have the same feeling. You really need to have a very wide-based flap, almost on the anterior wall of the ear canal. I think it's a very good point. And Neil, I'm going to ask you to take a look at the chat line. But I need to take like 2 minutes to do some housekeeping work. I want to have the audience download the app so they could reach us.
Thank you very much again for being with us this afternoon. And tomorrow again we will have a very nice session, I think, from Miami, University of Miami. And let's talk about the frontal sinus surgery. Have a nice evening. Take care.